Hey, Geoff, thanks for joining. I think we're going to have a nice discussion about the Clarify trial, sponsored by Clarity Pharmaceuticals, that you've agreed to be the PI on. So thanks for joining us.
Thank you, Geoff. Good to see you.
Yeah, it's good to see you, buddy. It's kind of a fun one because this is a trial that is related to one that I've been running, the SECURE trial, where we're imaging and then doing therapy in prostate cancer patients with advanced prostate cancer. But now, because of this exciting data coming out from the COBRA trial and the PROPELLER trial that you remember I was talking to you about, Geoff, saying, hey, this looks like a really good imaging agent, and would you be interested in leading the Clarify trial? And so brought it to you, and thanks for jumping in on that. And I would just say for our audience, both Geoff Karnes in urology, one of my longtime good friends, and I are grant funded by Clarity Pharmaceuticals to run trials. So just to disclose that. But I wanted to bring in Geoff on this because he is one of my favorite urologic surgeons. He's a good friend. He drove a lot of the imaging data from Mayo Clinic that led to our FDA approval for choline, came out of his hard work and his whole team. And so I thought, if there's anyone who knows how to use imaging for surgery, I thought it would be Geoff Karnes, and brought the trial to you. And so, as we start the conversation here, is there something that you're hoping to get out of this when we go look at these untreated patients that are going to be imaged with this advanced PSMA agent from Clarity, the copper SAR-BIS PSMA? Is there something that you think would help in your practice if this looks promising?
Well, first of all, thanks for the invitation, Geoff, and those kind words and the introduction. I think anything that could potentially improve the care of our patients is something that I'm excited about, something that we hope to offer here for our high-risk prostate cancer patients. Despite our efforts in surgically treating high-risk disease, inevitably, about 30%, maybe a little bit higher, will have a PSA recurrence. Mm-hmm. That may be from our lack of detailed staging historically.
Yeah.
There is a potential that we could improve the management of these high-risk patients by imaging them preoperatively. Obviously, the $64,000 question is, doing this versus, going forward with the surgery without PSMA-based imaging and then seeing how they do postoperatively. However, what we've seen is really a shift in the diagnostic field. Mm-hmm. When it comes to prostate cancer. Most of our surgically treated patients, which are usually in the hundreds when it comes to even high-risk disease here in Mayo Rochester, most of them are coming from the outside rather than internally. Yeah. And the majority are definitely having PSMA-based imaging preoperatively. And so this was an exciting opportunity to see how we could potentially improve on that, although not mandated by the trial to have another PSMA PET scan. Certainly a lot of patients will have that done in conjunction with the study PSMA PET scan.
Yeah, and I mean, you highlighted potentially improve upon that, and I think that's really where I got excited about this. So you've got gallium PSMA 11, you've got PYL and Posluma and these other agents that are out there, and the data coming out of Australia on the COBRA and PROPELLER trial look like, well, if you wait 4 hours, if you wait 24 hours, because of the design of the drug with the 2 binding sites and the longer half-life, this is one of the first, and I remember talking about one of the first imaging agents that in this field that increases activity as you go out to 24 hours in the tumors. So like we literally are seeing in the data showing increasing amount of what we injected in the tumors. So we're seeing sometimes 2 millimeter lesions, and I can't imagine. I was actually kind of laughing when I saw that. I'm like, are you going to be able to find a 2 millimeter lymph node?
Yeah. Well, I mean, the hope would be that our surgeons can actually co-register the imaging with surgical anatomy. And, although we may not be able to completely feel or palpate because most of these surgeries are done robotically, we at least should know that lymph
Where?
node
Yeah.
packet, where. But you're exactly right. I mean, interestingly, what we don't know is, when we find these sort of subclinical, if you will,
Hmm.
nodes or even small bone lesions, by by intervening on them, are we ultimately changing long-term outcome? Most of us
Right.
feel that we are, and patients desire this. I mean, patients are asking for PSMA PET scans. Interestingly, in Europe, in their urology guidelines, what they will say, or what they do say, is that you should treat the patient regardless of the PSMA PET scan.
Okay.
Yeah. So if they, again, we can't turn a blind eye to a external iliac lymph node, because we're going to see that on the PSMA scans, whether it's the study, which we're
Hmm.
not blinded by, or just a standard ordering PSMA PET scan done here at Mayo. So there's a potential we're going to have more extended lymph node dissections with the study, which I think can actually be helpful, but certainly not in every patient. And there's even a push, definitely in Europe, which have had PSMA PET scans for a longer period of time, that if they have a negative scan,
Right.
maybe we can avoid a pelvic lymph node dissection, because they're not
That's
without.
really,
Yeah.
that's where I'm excited about this. To be honest with you, is if with the path correlation that this trial is supposed to give us, we're able to be fairly confident about what's real and what's not, which is something that we really don't have with the prior trials. If we can confidently or more confidently say that you don't need to go after the lymph nodes, you can reduce the morbidity of the surgery, and you can direct care in a more intelligent way. Like you said, I think that might, you tell me, be the biggest impact of the trial.
Yeah, I mean, certainly the negative predictive value has almost just as much weight, or as you alluded to,
Yeah.
more than the positive predictive value of really what's a diagnostic test or a biomarker.
Right.